Hi, my name is Bruce Lowe, and we're going to talk about building your QA program. So, first off, you become the new ED Quality Director. Congratulations. Then administration comes up to you and says, hey, we've been looking at the sepsis mortality and it's not very good. What are you going to do about it in the emergency department to help fix this? A couple of years later, you do a good job, you get promoted to chair. Congratulations. Then you find out you have some issues with some of your partners. You have one physician who discharged a patient and comes back in cardiac arrest 2 days later. You have another physician who had several unrecognized esophageal intubations. Administration comes back to you and says, hey, I think we have a problem. How are you going to fix this? So a little bit of background. Errors, unfortunately, are fairly common in the emergency department. If you look in the literature, it's thought that about 10% of all patients in the emergency department suffers from some sort of error. Now, the good news is the majority of those errors don't cause patient harms. The bad news is the majority of those errors are actually preventable. Unfortunately, the culture is set that there's not a lot of incentive to report when somebody makes a mistake. If you think about it, if you make a mistake, you give a wrong dosage of medications or gave the wrong medication to the wrong patients, and you report that, what typically happens is you undergo some sort of disciplinary action yourself, as opposed to, hey, what happened? What can we do to make things better? So why do QA? Well, the first question we want to know is, how are we doing? You don't know unless you ask the question and look to find out. The second thing is about mitigating risk. If you work in the United States, for instance, very litigious in terms of medical legal actions when patients have bad outcomes, and so having a solid QA program can help mitigate some of those risks. And lastly, and probably more importantly, it's about improving patient outcomes, right? We want to make sure that if there are issues, what can we do to prevent bad issues from happening, especially or bad outcomes for patients? It's about patient safety. And lastly, it's also about reducing clinical variation, right? So why is it that you may have one physician that orders more CT scans compared to another, and yet their outcomes are the same, right? What can we do to reduce clinical variation and make it safe for everybody? All right, there are several types of errors we need to talk about. The first is called a no-fault error. Essentially, what that means is bad things happen and it's nobody's fault, right? Sometimes you can't predict when people are going to have bad outcomes. And if you look prospectively, what happened, there really wasn't anything in terms of opportunities to make things better or prevent their outcome. Next are system errors. And what that really means is that there are issues outside the control of the individual physician or frontline staff that may them lead to the error or problem. And lastly, there are cognitive errors. Now, these are individual that goes down to, and they're really broken down to two different kinds. There's knowledge based deficits and errors in decision making process. So how do we define quality? Well, it's a difficult one to answer. And if you ask 10 different people, you'll get 10 different answers. I also think of it as one of the U.S. Supreme Court justices when he was asked to define how do you define hardcore pornography, and he said, "I know it when I see it." And I think historically, quality has been somewhat of a similar approach where you can kind of know it when you see it, but it's really hard to put into words. What does it actually mean? When we start off with this quality journey, there's three questions that we like to ask. The first is, what should we measure? Second is, how do we measure it? And lastly, and probably more importantly, is when we get this information, what do we do with it? So first off, what should we measure? Well, if you think about it, there's really two kind of buckets. One is measurements that are patient-centric versus those that are surrogate. Now, if you do research, you know that ideally we have some sort of patient-centric outcome, such as mortality or reduced disability. However, we know that oftentimes those are fairly lofty goals. They are often require multiple different stakeholders, multiple variables, and they're hard to kind of measure in effect to a singular change. Oftentimes, what we end up doing is measuring surrogate markers. For instance, we know that having long wait times in the emergency department leads to worse patient outcomes. So a lot of times we do surrogate markers, right? So what's our length of stay for patients, right? How quickly can we see the patient from the arrival to the emergency department to when they can be seen by a provider? We can also look to guidelines, whether they're national government benchmarks or registries or medical society recommendations. For instance, we know that aspirin is good for giving people who are having heart attacks. Those are all the guidelines, and so those are probably a quality measure. We know it's relatively safe to say that this is something that we should be doing, and we should be measuring it. And then ideally, you want to be specific to the emergency department. Start small, make it ED-centric. Uh, if you think about sepsis, for instance, ideally we want to be able to do interventions or quality measures to help reduce sepsis mortality. But we know that when people get admitted to the hospital with sepsis, especially with septic shock, it's not just us in the emergency department, but it's also what happens as an inpatient in the ICU, the nursing care. And so there's all those other things that affect us. So that may, in of itself, may not be a great ED measure from a quality perspective. Then how do we measure it? Typically, it's retrospective, right? Sometimes something triggers it, a bad outcome or a patient complaint, and that usually triggers some sort of quality review. Ideally, you will be able to do prospective evaluation. You will take a measure, see how we're doing it, regardless of patient outcome, to see if we're doing what we're intending to that we wanted to do. And then once you have figured out kind of the what you're going to measure, you're going to figure out how you're going to measure it. Ideally, if you have electronic medical record, it can be automated and quick and easy to get the data. Oftentimes, though, you may have to go through the chart, manually extract the data, and that requires a fair amount of effort and resources. If you don't have a lot of time or resources, you may not be able to tackle certain quality measures. You want to make sure your QA team is competent. They're trained to know how to extract data and how to interpret it. And lastly, you want to make sure you standardize the process. So whoever is extracting the data and reviewing it is doing consistently the same time every time, regardless of individual or who's doing it. And lastly, what do we do with this information? Well, ideally, you have a goal set up, what you want to do, what you want to measure, and what kind of outcome you want to achieve. You measure it, you have some sort of intervention, and then you remeasure it to see what your performance is. Going back to sepsis as an example, for instance, let's say you want to measure compliance on lactic acid on those who have sepsis, right? So you want to measure it, see how you're doing, do an intervention, go back and see if the intervention make a difference or not. Some other tips in terms of building your QA program. A lot of times it's great to get feedback from the front line in terms of what they think are issues that need to be addressed. Having a QA committee that's diversified with various stakeholders. So for instance, in your emergency department, not just having an emergency physician review cases, but you may have a nurse to review what happens on the nursing side, or you may have somebody from radiology to review issues that involve imaging and so forth. You also want to do a prospective evaluation. So a lot of times when we get a case, it's because something bad happened or some sort of adverse outcome. So we kind of know what happened. We know the punchline. But what we really want to do is take it from the perspective of the individual that's going through the case prospectively. What did they know at the time, and did they make reasonable decisions knowing the information that they had? And lastly, you want to be as transparent with this process as much as possible. If you have policies or procedures or forms, make it available to see what people know, so what the process is like. What you don't want to do is turn this into a witch hunt, or at least a perceived witch hunt. So let's give a couple examples here. So sepsis. In my institution, we have a multidisciplinary committee. Now it's involved folks in the emergency department, like physicians and nurses, but also those on the inpatient team, the admitting hospitalists, the intensivists, inpatient nursing, administration, lab, imaging, all are part of our multidisciplinary team. Pharmacy. From an ED perspective, we like to focus those are ED-centric. So early identification. Are we giving appropriate and early antibiotics? Lactic acid ordering and repeat lactic acid ordering after resuscitation, and of course, are we giving appropriate fluids? And so we can measure that as a bundle compliance, and so it's a surrogate marker. It may not affect the patient-centric outcome of mortality, which is kind of the ideal outcome, but using a surrogate marker, things that we know can improve mortality, we can see at least from an ED perspective, are we doing quality work or not? Ultrasound. A lot of times in this day and age, most people are being trained with point-of-care ultrasound, but if you've been practicing for a while, you may not have gotten training in point-of-care ultrasound during your residency. In our institution, we have specific rules about who can do point-of-care ultrasound, just because we know that if you do point-of-care ultrasound, and if you're not really sure what you're doing, you could make the wrong diagnosis and lead to patient harm. So if you don't meet those criteria, you cannot do or supervise point-of-care ultrasound. We also have specific triggers of which when we do QA or review those ultrasound cases. And then we also prospectively review about 20% of all ultrasound cases to look for quality, right? Image acquisition, was it adequate or inadequate? Were the images interpreted correctly that were obtained, right? Even though there wasn't a bad outcome, we want to know ahead of time, are there things that we can do better so that we don't run into an issue where somebody misinterpreted something and leads to a bad outcome? And lastly, intubations. So we do have a very strict criteria about when we do reviews for quality for intubations. As examples, and there are things that we do for our prospective. For instance, we review all trauma intubations. And the reason is we know trauma airways are all difficult airways. We want to make sure that we're all doing it the right way and there's no opportunities for improvement. We also look at intubation procedure numbers. If we know that on a yearly basis, it's a technical skill. If you're not doing a lot of intubations, well, maybe your intubation skills may not be up to snuff. And so if you don't have enough intubations, we actually pull individuals to the sim lab to look at to see, do we think that they have adequate skill sets, or if there's concern, do they need further education? And lastly, in our institution, we do make all physicians take a difficult airway lab every 2 years. A lot of different airway equipment or backup airway equipment that exists. If you don't use it very often, you don't maintain that skill set. We also know that most intubations are fairly smooth, but the number of difficult intubations can vary that you may have experience with. And so if you haven't had a lot of difficult intubations, you may lose that skill set. So going through every 2 years, doing it for everybody, regardless of how many you've done, really helps kind of improve the quality, and we're not singling people out. Now, there is a word of caution when you do quality. Some metrics may not be that useful, and you may have some unintended consequences, right? So you may kind of influence or say, what, we want certain, for instance, length of stay to be short, and people start taking shortcuts in terms of their care and evaluation of the patients, and then you have some quality issues as a result. So be careful about what quality measure that you're doing and potential unintended consequences. So an example, 72-hour returns is a very common one that we use in the emergency department as a measure of quality. Well, it turns out it's actually a lot more complicated, right? Is it expected versus unexpected? Let's say you do an IND of an abscess and they don't have adequate follow-up, so you want them to come back to the emergency department in a couple of days for a wound check, right? Perfectly acceptable, right? Nothing wrong with that from a quality perspective. Then there may be issues of threshold admission. Let's say somebody has cellulitis. We know that we try not to admit people if we don't have to the hospital. You send them home with antibiotics. Maybe they come back the next day. It's not any better. And somebody may say, you know what? We'll just admit you to the hospital because you quote unquote failed outpatient therapy, whereas they really hadn't enough time to say if they actually failed or not. So in of itself may not be a good quality metric. If you look at studies that looked at this particular metric, they've actually questioned the value utility to say, is it quality or not? And lastly, think about a balanced scorecard, right? So you want to measure some things, let's say length of stay, throughput, and flow. We know patients who stay there a long time, it affects their quality as well as everybody else because of limited resources and delays in taking care of patients. But you don't want people making shortcuts, as I mentioned before, that may adverse their outcome. So looking at other things such as their stroke care, STEMI care, look at maybe 72-hour returns. In those instances, at least those with unexpected admissions to the hospital or some sort of adverse outcome may be worthwhile in that aspect. And then looking at other things too, like what was your nursing resources like? We know that since the pandemic, we've been strapped for resources, nursing in particular. And so if you have things that you're not able to meet from a quality metric standpoint, then maybe a reason is not apparent, such as not having available enough resources. So in conclusion, do develop a QA program. Use it as an opportunity to improve patient care. When you go through the journey, make sure you standardize the process, make it transparent as possible so it doesn't feel like a witch hunt. And then when you do focus on or identify opportunities for improvement, focus on things that are system issues as opposed to individuals. It's a pleasure giving a talk to you. I appreciate taking the time. If you have any questions, that's my email. Feel free to reach out. Otherwise, I hope you enjoy the rest of your conference. Thank you.